All right, so like I said, this is an ongoing series. We just quickly before we get started, I wanted to let you know that we are planning events for upcoming Digital Health Week, which is the week of November 14th to the 19th. We'll have a keynote event on November 17th. It's in the afternoon. It's a hybrid event, so there'll be in-person attendance for speakers and a networking event in the Chan Auditorium. And then we'll have some vendors and some food after the short speaker series. So please stay tuned for registration info for that. Once again, this year, as part of Digital Health Week, we're also having an ongoing virtual poster presentations. These will be hosted on our private YouTube channel. And the call for abstracts is now open. So if you are working in the digital health research and innovation space and you have a project that you'd like to present, please go follow this link. And if you are a trainee and you submit to this competition, you're automatically entered for a chance to win the best poster prize. And so more information can all be found in that registration link. And the theme for this year's event is putting digital health to work. So we're looking for results and examples of either ongoing or completed projects. So with that, I want to formally welcome you to this month's seminar. I'm delighted to have a couple exciting speakers. Before we do that, I just want to acknowledge that the BC Children's Hospital and Women's Hospital and Health Center, as well as all of our official affiliated research institutes and the university that many of us are a part of, are on the traditional, ancestral, and unceded territory of the Coast Salish peoples, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. I myself, I want to acknowledge, I live on the traditional and ancestral territory of the Sea-Shelp Nation. And I want to ask you to take a moment to just reflect on your own location and your position and commitment to truth and reconciliation with the Indigenous people on whose lands we reside. Before we started this, Maggie and Louise and I were having a conversation about the process of land acknowledgement and how it's something we're continuously learning to do better. So I appreciate you listening to that one from me and taking the time to think about the meaning of those words. So I'm going to stop sharing my screen and give Maggie a chance to share hers. Our first speaker is soon to be Dr. Maggie Kinshella. So Maggie is the Global Health Research Coordinator with Preempt, as well as IMCHA and BEMEC and several other projects within the Department of Obstetrics and Gynecology and Pathology at UBC. She's also a qualitative research consultant. She does extensive work in communities in Malawi, Mozambique, India, Pakistan, and many other places in the world that I'm sure she'll discuss with you. Maggie is also a PhD candidate in the Women and Children's Health Sciences program, working with Dr. Rajavel Elango and the Elango Lab. And Maggie is here today to talk to us about theories of behavior change. So please take it away. Oh, sorry, before you start, I just want to mention that if you have questions throughout the presentations, please put them in the chat and you can direct them specifically at me if you're not comfortable with everyone seeing them, or to everyone, whatever works best for you. So thanks. Go ahead, Maggie.
Great, thank you. And Beth, I just wanted to confirm, you see my slides fine and everything? Okay, perfect. So my name is Maggie Kinshella, and I feel incredibly privileged to live, work, and play on the traditional and unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So the objective is to provide an overview of 5 major behavioral change theories I'll describe the components that make them unique, as well as their philosophies and historical context that I believe really grounds our approaches and is helpful to reflect on when considering your own application. Don't worry about reading everything on this diagram. It is going to be our roadmap through the presentation today. And lastly, I'll briefly discuss a digital health example. So early theorizing about behavioral change emerged alongside this idea of development, or this policies around development. Development initiatives as a major government activity that extended beyond national borders began after World War II with the rebuild of Europe and as former colonies in Africa, Asia, and Latin America gained independence. This early generation of development and development communication studies in the 1950s was dominated by modernization theory, which assumed a unidirectional process from expert to public with a focus on disseminating information through mass media, which would which they would see, would then persuade people to believe, think, and act in certain ways. Development was uncritically assumed to be modeled after Western models, and culture and traditional practices were seen to be the problem to kind of educate beyond. Sorry, my slides were just acting up a little bit. As you can imagine, there was problematic issues with that focus. And implementators realized that the transmission of information was only half of communication. Programs also needed to consider how information was received and translated into actions by individuals. This individual approach was strongly influenced by pioneering studies in social studies and emphasized the process between information, individual decision-making, and health behaviors. Social psychology studies, sorry. So in the 1950s and 60s, the US Public Health Service was seeking to understand why some people did not accept recommendations that would help prevent diseases or screening tests, even if they were affordable or free. So social psychologist Aaron Rosenstock and colleagues developed a health belief model, which suggested that behavior is determined by perspectives, that they are personally vulnerable to the condition, and that the disease would have severe negative consequences, and that taking the advised action to avoid the disease is effective and does not entail overcoming barriers such as cost, convenience, pain, and embarrassment. Application of this theory includes addressing personal risk perceptions and beliefs in the severity of the disease, identifying key benefits and barriers to change, and demonstrating the positive results of change. A strength of this theory is the focus on perceived susceptibility and barriers, which are found to be strong predictors of behavior. However, a limitation is that it's a cognitively based model and does not consider the emotional components of behavior. In the 1970s and 80s, social psychologists further suggested that individuals weigh pros and cons of their behaviors, and the intention to act is based on their attitudes and social norms. So attitudes in this context involved what they thought about the issue, which includes health beliefs, and social norms involves what they think other people think about the issue, especially respected others. As it captures both of these concepts, intention was considered the best predictor of behavior in this theory, and perceived control over and power to affect a condition was later added to the expansion to the theory of planned behavior. Application of this theory would include creating messages that affect attitudes and norm clarification. A strength of this theory is that it starts to take account affect within its emphasis on attitudes. However, its limitation is the fundamental assumption that individuals are rational actors that are logical to their own behavioral, normative, and control beliefs. So the previous social behavioral change theories focused on individual level decision making. And the next level of theories start to look at learning through interactions with others and strengthening skills for self-confidence. So interpersonal theories such as social learning theory and social cognitive theory suggest that people have little incentive to act when they do not believe that they could produce the desired effect by their actions. And these researchers argue that self-efficacy is the major basis of action. These theories suggest that behavior is the product of an individual's learning history, present perceptions of the environment, and their intellectual and physical capacities. Key concepts of this theory include observational learning, where people learn and decide how to act by observing the actions of others, observing the apparent consequences of those actions, and considering those consequences for their own lives and trying the actions themselves. And of course, self-efficacy is an important concept in this theory, which includes the development of skills and confidence in one's abilities. The emphasis on building self-efficacy through skill building and role playing, as well as the focus on observational learning via role modeling and narratives, has made social cognitive theory one of the most applied theories in health promotion interventions. It is one of the most studied behavioral change theories, and there is considerable evidence for the role of self-efficacy. However, while there's more consideration on the interactions of others, these theories are still focused on the individual rather than the setting. Though they were well studied, many theories driven by psychological research has been critiqued as still being overly individual focused. So next we will look to some community models that highlight populations and the environment of health behaviors. So diffusion of innovation was a powerful shift in thinking about considering behavioral change in communities. Because of its focus on innovations, it has been considered for digital health and other innovative health interventions. Pioneered by American sociologist Everett Rogers, it seeks to explain how new practices can diffuse through a given social system to the point that it becomes a social norm and introduce the term early adopter. It suggests that there is a classic bell curve of people in the process of adoption, from innovators who are active seekers of new ideas, early adopters who are very interested in innovations, but they're not the first to sign up, the early majority who need external motivation to get involved, the late majority, including skeptics who will not adopt a new innovation until most of their social network does, and then what he termed laggards, who are the last to adopt. Innovators and early adopters are the trendsetters in a social group and begin to model the new behavior to others. And as they do so, they begin to alter the perception of what are normal behaviors, and others may start to adopt this new behavior. In the end, according to this theory, as a new practice has been diffused through the social network, community members are expected to adopt the practice as normative. So application of this theory includes working with opinion leaders in a social network to conduct small group meetings, as was the example of the Stop AIDS program in San Francisco in the 1980s, which is perhaps the most famous example of the diffusive innovations model. However, while this theory recognizes context, the application of this theory in low and middle income countries may be challenged by the lack of explicit guidance on addressing local social, cultural, and economic obstacles. So the ecological models in general build off of the diffusion of innovation theory, but maybe are less structured in those different categories. Instead, there is more of an emphasis on building momentum for social change and emphasizing these tipping points and creating positive environments for change through local participation, collaboration, and leadership. Ecological models emphasize sustainability and building critical mass through empowering people, both with the motivation and skills to change behavior, as you have seen in some of the earlier theories, but also seeking to address the limiting environments and policies that make it difficult to choose healthful behaviors. Interesting, social and behavioral change communication. It's very popular in implementation programs, such as with UNICEF and USAID, but not as much theoretical literature on the topic. What I like about the ecological models is that it conceptually makes space for building a foundation for change, understanding that there can be many small changes that occur, perhaps in the background, until there is enough momentum that change becomes immediate and visible and unstoppable. It becomes maybe institutionalized. So if you're familiar with logic models, it maps this theorized pathway of change, even though a specific intervention may not be feasible to capture the whole journey. It shows that the building blocks are getting put in place. However, as you can imagine, and perhaps this is why it's less studied, community change is really hard to measure and is often less straightforward than individual and interpersonal level behavioral change theories. So ecological models have a lot of moving parts and tend to focus on creating health-enabling environments. Application of this model includes a multi-level intervention that engages people in dialogue that links root causes and community actions, empowering community members to expand their power to create desired change, and community-based health programs. Strengths of the ecological models include working on multiple levels, emphasizing community participation, an awareness of complexities, and understanding that there can be an extended build-up period before the tipping point of sudden change. While intuitively the concept of community engagement and active involvement of the target population would be a promising initiative, the evidence is quite limited perhaps because there isn't as much theoretical foundation and because change can be hard to measure. So now I'm just going to give a quick example with a digital health innovation that is very close to Beth's heart. Peers on the Move, or POM for short, is a mobile health application that was developed to support community health workers to identify and manage women at risk of adverse outcomes from preeclampsia. It was implemented in India, Pakistan, and Mozambique during the CLIP trial alongside community engagement. Health worker evaluation were completed in each of the 3 countries. And I've put the QR codes posted on this slide here to link to the individual country publications. But overall, healthcare workers found POM easy to use, useful in guiding their activities, and pregnant women were said to have received their counseling more seriously because of POM. Many of the community health workers reported that POM improved their knowledge, more confidence in their skills, self-efficacy, and also strengthened their reputation as professional healthcare workers in the communities that they served. So taken within the behavioral change theories discussed in this presentation, POM had high acceptability among community health workers, and from their reports of how it was received among pregnant mothers and their families. However, systemic challenges, including a lack of transport and distance to the facility, poverty, sometimes concerns about quality of care at local health facilities, presented barriers to following through with the referral recommendations. So from an ecological approach, there were still some challenges to that enabling environment. So maybe we're starting to build towards change, but we're not at that, may not be at that tipping point yet. So very briefly, here's an example of breaking it down by an ecological approach to understand the implementation of POM in Pakistan. So this was based off of 3 key informant interviews with 2 lady health supervisors and 1 senior medical officer, as well as 3 focus group discussions, including 63 lady healthcare workers, including 62 kind of community health workers, which are called lady health workers in Pakistan. And so this health worker evaluation of the POM app looked at the issues that rose around the usability of the technology itself, themes that looked at the impact of POM on the community health worker, and then wider to the women they interact with, and then potentially on the community relationships and the local settings of maternal health, as well as the larger systemic challenges that impacted the feasibility of the POM app to support behavioral change. And then the relationship, the impact goes both ways in that some of those technological features of the app influenced the impact on the healthcare workers, on women, on the communities, but then some of those challenges and barriers to implementation would feed back to influence how the app would be used. So in summary, in this presentation, I briefly overviewed 5 major theories of behavioral change that expanded from individual decision-making to self-efficacy and social learning to looking at the processes of community change. And then we very briefly discussed an example of the POM app to understand the different levels of interactions with digital health innovations, as well as the critical need to understand and consider kind of community level and systemic factors where change may occur slowly until enough momentum has been built to cross a tipping point, as well as also some of the challenges of measuring community change. So I'll end there. Thank you. And I'll welcome questions, I think, at the end of the session today. I've also put my email there in case anyone wants to contact me.
Thank you, Maggie. That was a fantastic theoretical overview, and it is really cool to see how the theories evolved over time and built off of each other as we learned and developed this field. And so, like Maggie said, if you have a burning question now, feel free to put it in the chat or raise your hand, but otherwise we'll move on to our second presentation just so we give our speakers lots of time and then have some questions at the end. And so with that, I'll welcome Louise Masse, if you want to share your screen. So Dr. Masse is a professor in the School of Population and Public Health at UBC and a level 3 scientist at the BC Children's Hospital Research Institute. She leads an active research program in childhood obesity, where she focuses on evaluating policies and capacity building interventions to influence child health behaviors, specifically physical activity, sedentary and dietary behavior in multiple settings, including childcare, recreation centers, and schools. She also develops and evaluates gamified lifestyle modification interventions, as well as works towards understanding how transitional periods, specifically the transition from elementary to secondary school, influence a child's physical activity, sedentary and dietary behaviors. So I'm really excited to hear a bit more about your work. Please go ahead.
Thank you. And I'm assuming my slide is shown correctly. Yeah. So I just wanted to thank you, Beth and Maggie, to start off with land acknowledgement. I'm also on the unceded and traditional territory of the Coast Salish people, which I feel very fortunate to sort of be here and and also reflect what it means for me to be here. So thank you for allowing us to sort of reflect on our position and the progress we need to make in moving forward. So what I'm going to do for this talk, I'm going to talk about integration of behavior change theory to design health apps. And I'm going to give you a case study of aim to be and then how we use that information, and then put a little bit more into practice, you know, what Maggie talked about, and then say like how this, the theories have influences the development of the app essentially. So before I just discuss what we've done in the context of aim to be, I want to acknowledge all the funding that was received to sort of develop this work, and to acknowledge also that MTB was co-created by the Childhood Obesity Foundation and IOGO. And my role has been to provide scientific expertise, lead the evaluation, and I have no ownership into the app as well, so that you could know what my role was in that project as well. So I want you to gain a little bit of an understanding of the theoretical strategy that we use and why, and then the critical step that we've done in evaluating the app. But I really want to get you to start to think about, you know, we have to be somewhat intentional what we put into our app, so we could really understand why it works, doesn't work, and for who and under what conditions it could support behavior change. I always tell my students when I develop an app and then everybody says, like, let's do an RCT. Let's look at what the outcome is to see if it changed, you know, the main outcome. And I said, even if it's positive or negative, we don't learn anything in terms of how to develop an app like that. That whole paper is really not that helpful for you to sort of explain why it works and why it doesn't work. So that's what I want to get you to start thinking about, is that we have to think about the other side of it and then the mediators we're targeting. And I'm going to hopefully do a good pitch on that. So I'm not going to spend a huge amount of time in just explaining what the app is and giving you videos. You could access it. It's free. And then it's available information at Childhood Obesity website. You could get more information, but it's a free app that was meant to actually support Canadian family with children 10 plus years of age. And it really aims at sustaining behavior change in 4 primary areas: healthy eating, active living, screen time, and sleep. And it has an emphasis on family and peer support, healthy body image, strong self-esteem, and makes people reflect how their behavior is linked with living green, you know, how physical activity could support, you know, a healthy lifestyle, and as well support, reduce your carbon footprint and so on. And I'm going to give you a very quick overview. It's a multi-component intervention that has many aspects as well to the intervention. And I just need to move something here off my slide. And it has, you know, typical what you would expect an app that has gone through a lot of development. You start with, it's actually is I'm going to talk essentially on the child perspective, but the parents app is essentially the same. So you start with a journey that is actually self-guided, and then the onboarding has a personalized experience in terms of, you know, deciding what your homepage is going to look like, and your landing page is going to look like. And then eventually you land into the AIM store, where you could select your individualized aim. Are you going to focus on nutrition, screen time, what aspect? And then as you complete aims, you earn currency, but then for specific aims, you have specific tasks and quick wins that you could actually align with your progress. And then some of it is meant that you have incremental steps. There's a whole map center. Number 4 here is at the map center, where you could actually, you know, set goals, monitor, and we could provide feedback, and you could review behavioral goal. And that's really a cornerstone of, you know, how do you support behavior change. There's a sections where you have articles where you can have information to support how you achieve your aims. There's a social wall to sort of use where you could exchange. There's also, in the version that I have done most of the evaluation, version 2, there's an aimbot life coach, and actually where you could actually ask your questions. There's also stories where you could actually use, you unlock the currencies, the story with currencies, and you have your own adventures that support your decision making. And then, you could come up with, a typical story, what a teen would encounter, and then say, well, would you do A or B? And then you could have sort of a self-guided journey. And if you want to have more information, we've published the theoretical underpinning of that intervention in 2020 in the trial journal. And I'm going to focus a little bit on the theoretical framework to take you back to Maggie's presentation in terms of, how do we use theory to develop intervention, and what's the theoretical underpinning of AIM to be? And so we actually focus a lot more on individual and as well as interpersonal. So at the lower level, because when you sort of develop an app to sort of support behavior change, is that this one tends to focus more individual and interpersonal level. We were quite influenced by social cognitive theory, the self-regulation component, where there's a lot of information and data. So theoretically, what self-regulation says is that self-monitoring is really important. And initial self-monitoring, when you look at your behaviors, to raise awareness and to help you set realistic goals. And the next thing is that you have to have continuous self-monitoring for an evaluation component. So there's two aspects of self-monitoring that's really important. And then it's important that feedback and review of behavioral goal is integrated into the intervention, because this is kind of the feedback loop, is that behavior change is not something you do one time, but it's something you struggle over time. And you all know that if you're trying to become more physically active, is that you probably have time, you're doing a great job, other time you're inactive. It's a continuous thing that you have to work in and weave in. And self-monitoring and goal setting requires some level of fidelity, consistency, and temporality in order to work. So that's what we know from Bandura's social, cognitive, and aspect of self-regulation. Mean that you may have to do the self-monitoring and goal setting more often at the beginning as you're learning how to change your behavior, but at the maintenance phase, you may still have to do it because you may be prone to sort of relapse or, sort of not be as consistent in your behavior. So we took that into account. And then what we did when we were developing is that we would look at the literature as what do we know about the behavior change technique that people include in their intervention? Which one should we include? And so this is an older review, but this is what was the foundation at the time when we developed the intervention. It's based in 2017, but there's more information. So there's a lot of review out there that looks at what are the behavior change technique you should include in intervention, and these are kind of linked to specific theories. And what we had at the time is we didn't have as much, there's more now, but we didn't have as much information on teens or preteens, because that's who we were targeting for intervention. So what we had at the time, we had more information in terms of how, and in the context of health promotion theories, interventions, specifically in the app context for changing nutrition and physical active behavior or combination. And we had more information into adults. So this is what the foundation that we use, because we didn't have at the time, but then, certainly the field has changed. So what we knew at the time when we developed the intervention is that, so this is a meta regression. So it's multiple intervention. And when people say, what technique did they include? What seems to promote initiation of behavior and maintenance? Because we also know that we could change behavior. We could start a behavior very quickly, but maintenance is key. So we know that goal setting is important. So everything in green was significantly associated with promotion of behaviors. Light green was also associated, but not as strong. And then red has a negative association that didn't actually work. So goal setting was quite important. Review of behavioral goal was quite important, self-monitoring, and then the two in darker green more important, feedback and demonstration of behavior. So you could see that we have some validation in our context of the theory of, self-regulation theory from Bandura's. Promotion of maintenance, promoting maintenance of behavior had very similar, but had a bit more like feedback became more important, making sure that graded tasks and making sure we had social support. And lastly, that we actually change the environment, that we don't focus only on the behavior, but we think about how the environment could support behavior. So very important as well. So when we took that into account is that we developed our conceptual framework for our intervention called aim to be. And so the behavior we wanted to change are listed right on the right side: fruits and vegetable intake, sugar sweet beverage intake, dietary quality, physical activity, screen time, and ultimately we want to change healthy body weight or decrease ZBMI. And we thought about like, what are the mediators we wanted to target with our intervention? Is that we want to activate self-regulation skills, people having those skills. And so what we use is we use self-determination theory to say, well, we know that to activate self-regulation skills that we have to support intrinsic motivation. Like people have to be intrinsically motivated to change their health behavior. We also have to improve their self-efficacy. And the way we do this from self-determination theory is that people, they need to have enough autonomy. They need to relate to the context. They need to see this as important. And we have to improve their competence through mastery and then, you know, and then small skills and then graded tasks. So all of the program component that I listed is that aim, stage, task, map view for self-monitoring and all that, setting and feedback, article, knowledge centers are really targeting these aspects of the intervention. This is what we consider the active ingredient of the intervention. So we know that this is important to change health behavior, the individuals, but we also know that it was not enough. So what we're missing is that, and we added intervention, is that we know that we need to promote engagement, maintenance of the intervention is important. And then we have to think about how do we stay people engaged? How do we make the experience enjoyable? And this is the other part where our partner, IOGA, was really important because they had developed the Accredo framework, which they have extensive knowledge of developing basically games. How do we keep people in the games? How do we keep people, you know, to come back to the app? So it has to have, Accredo stands for agency. You have to personalize the app. Challenge, you have to create challenge, and then, you know, like you have to have incremental stages. There needs to be some uncertainty. It can't be just the same thing. You come in and say, well, I know what I'm going to get. Like there needs to be some level of uncertainty. There needs to be some level of autonomy so that they could discover and explore and have some level of choices. And there has to be some outcomes like rewards, currency, and collection. So this is the components of the program on the left, like the onboarding to make it fun, to personalize it, having bonuses, quiz, interactive stories, and currency that we say, like, these are the components, that the gamified component that should bring back people into the app. Now, from self-determination theory, you have to be careful about having not too many gamified components to distract, because that also is the extrinsic motivation for you to actually change your behavior or to use the app. And that could actually distract from your goal, because through behavior change, you have to be intrinsically motivated. You're doing this for yourself. You want to be physically active because it matters to you, not because somebody, you know, is going to perceive or think like, you know, that is a good thing for you. You're doing it for yourself, not to please others or to meet external ideal goals, such as, you know, losing weight, not because you know it's healthy for you, because that's, you know, the body image you wanted to project. And then the other thing is that we also know that when we develop the app is that we could focus on the individuals, but the environment is key. And we know for social cognitive theory that, you know, individual are important to target them in terms of changing the behavior, but we have the other component is that the environment needs to support individual change in behavior, because we're working into a closed loop in terms of changing behavior. In this case, that we were focusing more on children who had overweight and obesity, is we said, like, well, the family is really important, but they need to also have social support. So the familial environment needs to actually support the change in the children, and then provide the, you know, the modeling that is needed, the reinforcement in terms of the parenting practices. So there actually is a companion app that is meant to actually support the children's change in behavior. as well as reinforcing the overall family change in health behaviors, because it's not going to happen in a vacuum. And there's also social support, peer through the social wall, virtual and life coach. And these are all the elements and theoretical elements that we've included in the app. And when you develop an app, it's actually useful that you could use the web analytic and code every component of the app, the program components, to say, what is it targeting? Social support, is it targeting? Intrinsic motivation, is it targeting? And once you have that, you could say, you know, how much of these components they use, and then is it working? Because if they're not using any aspect of your app, for example, if all of my teams were usually using mainly the quiz, the interactive stories, which has a little bit of the content, but not enough, we wouldn't expect any behavior change. So you have to monitor what they're using and to what extent they become distracted or using the active ingredient of the app. So that's the theoretical underpinning of AIM to Be. It has gone through a lot of development even before it became an app, because it was initially a web intervention, where the first component that was tested is whether it makes sense to link environmental concept with health behaviors, such as living green, and that was published and was quite well received. But when it was first developed as a web application, as people just didn't find it fun and it wouldn't stick with the with the interventions, this is when it switched to an app. And we did a pre-post evaluation initially, 4.5 months, with around 300 families, and then had the initial results, which was quite positive, except we didn't see as much change in physical activity. I'm not going to focus too much on the outcome of the intervention evaluation. We've published that, and I could add the references. I noticed that I don't have the reference here at the bottom. But we saw a huge amount of change, except screen time was in the actually, the screen time was in the correct directions in this in the pre-evaluation. And we moved on to a randomized controlled trials, where we focus on to our sample is a clinical sample. All of the other testing was not done in a clinical sample, was done predominantly on, the general population. We had 6 sites in Canada that's recruited, and we used Facebook, and we randomized them into intervention and control, and they received the intervention for 3 months. The control were waitlisted and received the intervention at 3 months, but the intervention group continued, and we monitored assessment at baseline, 3 months and 6 months. So we were able to look at the short-term efficacy of AIM to Be. And then we had several outcomes, and you could see who participated in the intervention. I'm not going to spend too much time, because I want to focus much more on talking about, how people use the app, and then what kind of information we get when we actually analyze that information. So we look at the behavioral outcome, see if it changed physical activity. We had a Fitbit. We looked at whether it changed health behavior. We had 24-hour dietary recalls, and screen times tends to be more questionnaires. We also measure height, weight, so we could calculate ZBMIs, and we also assess the mediators. Not going to spend much information on that, but give you a little bit of a quick overview of what the outcome is. The initial RCT aimed to be, when we looked at the intervention and control, we didn't see any impact on the intervention, which actually, don't get discouraged if you develop an app. That's why you need to monitor how people use your app, because it takes a long time to actually develop an app that is efficacious. So if we only focus on measuring whether we have an efficacy in intervention, it's like we don't have a lot to discuss right now, because actually the RCT, we didn't find an effect. We did actually monitor, I don't know if you remember when I talked very quickly about the design, is that we had our waitlist control that had the intervention. And then, so we have a period where we measure whether they actually, we just had the measurement period. And then we were actually able to actually look whether they changed their behavior because they had the intervention. from 3 to 6 months, and we had a period where we could say whether they change over time, and they serve as their own control. So when we have that group, we have much more of an effect in terms of in a positive direction, decrease at BMI, kick out from discretionary food, increase in knowledge of the Canadian recommendations for physical activity, nutrition, and screen time, and physical activity outside of school also increase as well. And we had an increase in screen time. I had one of my arrow in the wrong direction in this slide. And one of the key things that we have in that study is that we actually provided a Fitbit to all our participants. We provided it ahead of time, so we thought we would have a washed out period by the time they start the intervention. And we think what actually happened in the RCT is that they got distracted. It's like, here we have a Fitbit and we also have, an app. And so I think we had attention deficit disorder in terms of distraction with the Fitbit, and that's why we probably had some of the weight loss control effect a little bit stronger. But we didn't have an effect on everything. And what you really need to try to figure out is like, if you don't collect all of the web analytics, you don't really know what to change. So what we do is we could code everything, and then we could say like how much use people make of on the left side, like of the behavioral, like the active ingredient of the app. Like, do they use the aim, the task, they read the articles, they do the reflections, they do the check-in, and they monitor their health behavior and so on. And then the gamified components, do they actually use the collection, the quick win, the quiz, and so on? Do they get involved in the social ball? And then we use like a statistical procedure that's called late class analysis, where we could figure out like, how many people use and how people use the app. So we could say we have a fair amount of them that are not engaged with the app. They get distracted, and like they don't use many things. And so and we have some that we call dabblers, and then, so this is the children where they use in the components, and then in black is no use, orange is low use, and then blue is at high use. But they use some of the components, but they don't have really high use. They dabble with everything. Partially engaged is they engage a bit more, and you see much more blue, and then fully engaged is the very good use of it, but 15%. So we still have some issue of, people using the app as expected and as we would want, but we could actually look like, what kind of effect that we have when we have, when people are fully engaged. It's a small percentage, but what effect do we get? We could do the same thing with minutes. Like people will say, well, what if I use minutes? How many minutes people use the app? Does that relate to child outcome? And actually, in this case, and quite often, not always, is that we didn't find an association with how much time children spend in the app with child outcomes, but we found association with kind of patterns of use. And you could see that, especially when you add gamified component, you could say they could be using the gamified component over and over and over and over, but not using the active ingredient of the app. So that's why we didn't find an association with minutes in the app with child outcomes. And we also look at pattern of engagement of the parents. We have different kind of level of engagement. Again, we have a fair number of them not very engaged. Some of them that they engage with much more the social component. They're independently engaged. That tends to read the article much more, tend to be attracted with that. And then partial engagement, which with full engagement. When we looked at, if the parents are more engaged, the child are more engaged, we kind of have like a really good dose response relationship in terms of looking at parents versus child engagement. Engaged parents have engaged children, and unengaged parents have also unengaged children. So it's very important. And when we look at the different topologies where blue is, high engagement, fully engaged, dark orange, partially engaged, and then light orange, sort of the dabblers for the children, and then the black unengaged, we sort of see like clear patterns in terms of the relationship not in the right directions for the unengaged, and we would expect that. So when we look at child engagement, we could see a significant association with decrease in sugar intake, total energy intake, and unsugary beverage intake. when we look at the parent profile, which we had a bit more, we see that parental engagement is significantly associated with decrease in child's BMI and total energy intake. So you find a lot of information, and it could really start to tease out apart a bit more your intervention when you start looking at how people are actually using the app, whether they're using the active ingredient. And another thing that I didn't have a chance to actually weave it into my presentation is to also show like what component, what content they use. We code absolutely everything. So we could actually, look every aspect. What aims do the teen like to get engaged? Why are some of them being used or not? And then you could combine this as well with qualitative data to really try to figure out how you could improve your app. It's like, we see some effect into the app. We still see some problem in terms of engagement. But if you mainly focus on child outcome and really don't really look at, whether the mediators are targeting are, like, are you really getting that kind of use of the app that you want to have without the full web analytics, you won't really be able to actually improve your app. So app use is not enough to achieve the desired health outcome. That's what we found. But other people find the same. But apps have a role in supporting behavior change, but they require significant work in ensuring change in child health behavior. So don't be discouraged if you find that you develop an app, because everybody say, oh, we'll develop an app. They're much easier to sort of develop, and it takes a lot of time to sort of develop something that is effective. And if you go back to the literature in terms of in-person intervention versus an app, you get more engagement. You could actually monitor engagement much easier when you do in person versus an app. So it's even more difficult to get the behavior change with an app than versus other means. Patterns of engagement does matter, as well as child and parent engagement. And developing strategies to increase engagements are very needed to ensure that app meets the clinical outcome. And sometimes is that you have the right idea when you develop an app. You are targeting the right strategies, but you don't have enough engagements. It's a balancing between making it fun and building enough components that it doesn't detract, but that you need to figure out, like, how do you make people stick with the intervention? And then we still think that the strategies that we're using is good, but then how do we get people to sort of, continue to use it is what we need to focus on more. There's an excellent editorial in JAMA that was in 2013 from Sherry Pagato that says, we actually know what strategies people need to actually use to change their health behavior. We know what the recommendations are. Is how do we get people to stick with it is where we are. So if you are venturing into that area, is that where the science is? It's like, how do we get people to stick to their intervention is the biggest issue. So I just want to talk a little bit more about who our teams and partners are. Is quite a lot of people involved. And if you are interested in seeing the app, you could look on the Childhood Obesity Foundation website. There's a demo there, and you could actually get it from the App Store and download it for free as well. So I'm going to get rid of my share, and I hope that I left enough time for questions.
Have just a couple minutes. Thank you so much, Louise. That was an incredible example of not only the complexity of changing behavior, but the application of theory and how that can work and can influence your evaluation. The thing that really stuck out to me, and I think was something we found in the Peers on the Move project as well, is that changing behavior doesn't happen just once. It's an ongoing process. So the theories influence that initial change, but you also need to consider what will then maintain that ongoing change. And that's where it gets really complicated. Tibor, please go ahead. You should be able to unmute yourself.
Yeah, so thank you, Louise. That was a great presentation. Of those people that were very motivated, the one that were all the way on the right hand of your column, how many of those people had some sort of an event that could classify as a wake-up call? Like, I wonder if some of this, if people have different motivations coming into these programs, like, you know, something scary happened and therefore they're now
Yeah.
motivated.
Yeah, so we don't have necessarily that data. And what gets them to be engaged, like I don't know.
I'll use myself as an example here.
Yeah.
So I, a while ago, got something back from my blood work that said, hey, you're pre-diabetic. And all of a sudden I was way more, and then I lost a bunch of weight.
Yeah.
Because now I had something that motivated me. And then
Yeah, so in the clinical setting, because a lot of the people that we did recruit, so a portion of the people that we recruited in the clinical setting had actually probably all had interventions that would be, you know, like individual interventions. So they all had that. Like, I don't know what would make people sort of click in terms of, because we don't have necessarily that information, like yeah, I think it's hard, because if it's teens, like we certainly know for sure in the adult context, you know, when you get like a, you know, a diagnostic, is like, it's a very important teaching moment, and then people could actually really change their behavior, because there are, you know, times where, you know, it's very important. And then but we don't have necessarily that data that is sort of like why you're motivated, you know, why you're, you know, like, why is it important to you to change? Like, there might be some data that we could look back, but we don't necessarily have it. But there's certainly true that in the adult context, we've seen that. But I don't necessarily know with teens as much. Teens and preteens are really hard. I'm not sure why I'm studying them, I have to say.
Interrupt for just a second to say,